All right, let's dive right into this explainer. We're going to break down congenital spinal and cranial anomalies with absolute precision today. The goal here is to give you a complete conceptual understanding so you don't have to go deciphering a dense textbook. You are in exactly the right place. So we've got a highly structured roadmap for you. We'll be hitting the Filum terminale lipoma, how to evaluate and treat it, and then we're jumping into dermal sinus origins, spinal pathology, treatment, and finally, cranial dermal sinuses. Let's just get straight into it. Section 1. Filum terminale lipoma, often just called the fatty filum. The absolutely crucial point to grasp right off the bat is its anatomical isolation. A true filum terminal lipoma is a lumbosacral lipoma, where the fat is strictly limited to the filum terminal itself. It does not involve the conus medullaris. No exceptions. Now, if we look at cadaveric studies, the prevalence is actually hovering around 4 to 6% of the population, and somewhere between 0.24 to 4% when you're looking at MRI data. Now, here is what's truly staggering about this anomaly. Up to 95% of these cases identified on MRI completely asymptomatic. Because of this, most of the ones we find in adults are just incidental findings. You go in for an MRI for a totally different issue, and boom, there it is. But it's definitely not always a silent condition. When symptomatic tethering of the spinal cord does occur, and this happens way more commonly in kids and young adults, we see a very specific clinical presentation. Urological abnormalities are the predominant issue, making up 59% of symptomatic cases. That's followed equally by back pain at 32% and leg pain at 32%. And one quick note, these symptoms get significantly more common the lower the conus is actually located. This data really drives home the age disparity we were just talking about. Just look at the stark difference between pediatrics and adults when we look at associated findings. A low-lying conus pops up in 30% of pediatric patients with FTL, but only 8% in adults. A syrinx? Found in 12% of kids, but merely 1% of adults. It's definitive proof that these associated and, frankly, often more severe findings are vastly more prevalent in our younger patients. Moving right along to Section 2, FTL evaluation and treatment, from imaging to intervention. Let's see how all this data translates into actual clinical protocols. Because urological symptoms are the absolute chief complaint when this turns symptomatic, you can't just stop at a standard MRI. Routine urodynamics must be performed to accurately assess bladder function. As for the natural history, studies that followed patients for an average of about 3.5 years, and even ranging up to over 16 years, show that asymptomatic patients rarely develop new symptoms. They just generally remain stable. Because of that stability, surgical intervention should really primarily target symptomatic lesions, specifically those cases compatible with a tethered cord showing urologic symptoms. Now, some older literature used to advocate for prophylactic division of a fatty filum to stop symptoms from ever starting, but today, that's highly controversial. Really, the only time prophylactic sectioning is considered totally reasonable is if you're already operating in the lumbar spine for something else entirely, like a scoliosis correction. Okay, let's pivot away from lipomas for a bit. Section 3, dermal sinus origins and the embryological failure behind them. This embryological failure is just fascinating. Basically, a dermal sinus is a tract beginning at the skin surface that is completely lined with epithelium. It typically happens at either the cephalic or caudal end of the neural tube, though the lumbosacral region is definitely the most common spot. But why does it happen? Well, it's essentially a failure of the cutaneous ectoderm to separate from the neuroectoderm right at the precise moment the neural groove is trying to close during development. So now that we know how it forms in the embryo, let's jump into Section 4, spinal dermal sinus pathology. Let's dissect the physical traits going literally from skin to spine. Looking purely at the surface, the signs can be incredibly subtle. We're talking a tiny 1 to 2 millimeter dimple or sinus, usually sitting right in the midline. You might see hairs protruding from it, but not always. The surrounding skin might look completely normal, or it could have a port wine pigmented discoloration, or even be distorted by a mass underneath. For context, a presumed sacral sinus, where you literally can't see the bottom of the dimple when you retract the skin, pops up in about 1.2% of neonates. Now, here is a key anatomical detail. The tract from a spinal dermal sinus always courses cephalad. That means it dives inward and upward toward the head. That specific upward directionality is exactly what distinguishes it from a superficial pilonidal cyst. As that tract dives inward, it can widen at pretty much any point and form a cyst. When this happens, we have to distinguish between two distinct types, An epidermal cyst is lined with stratified squamous epithelium and contains strictly keratin from desquamating skin. A dermoid cyst, though, is lined with true dermis. Because of that, it contains skin appendages, like hair follicles and sebaceous glands, meaning it's going to be packed with sebum, cholesterol, and hair. And that brings us to where the real danger lies. If that tract expands intrathecally, it can actually present as a tethered cord or an intradural tumor, with bladder dysfunction usually being the very first red flag. But even worse, the contents of these tracts, the hair, the sebum, the desquamated epithelium, they are highly irritating. If they manage to shed into the dural space, they cause a severe, sterile chemical meningitis, carrying a huge risk for delayed arachnoiditis. It's just a highly dangerous environment. Because of that risk, here's an absolute clinical law you need to burn into your memory. You must never, ever probe these tracts or inject them with contrast during an exam. Doing that can instantly precipitate the exact infections or sterile meningitis we're trying to avoid by literally pushing those toxic, irritating contents deeper into the nervous system. Just don't do it. So how do we actually safely evaluate it? We have to rely on a really strict protocol. The physical exam needs to focus entirely on detecting any abnormalities in sphincter function, lumbosacral reflexes, and lower extremity sensation. Right at birth, ultrasound is going to be your absolute best diagnostic tool to hunt for a mass inside the canal. Once the kid is a little older, an MRI becomes the gold standard to map out the full tract, where it attaches, and any intradural masses. Keep in mind, plain X-rays and CT scans are pretty much useless for showing these ultrafine tracts. We only ever use plain X-rays for operative planning if a complete laminectomy is anticipated. All right, on to Section 5, spinal dermal sinus treatment, specifically surgical excision. We know the dangers, so how do we actually fix this? The literature on this is incredibly clear, because clinical outcomes absolutely fall off a cliff after an intradural infection occurs. All dermal sinuses, with the sole exception of simple tracts terminating right on the tip of the coccyx, should be surgically explored and completely excised. And this is crucial. This has to happen prophylactically, way before the development of any neurologic deficit or sign of infection. Generally, performing the surgery within the first week of diagnosis is considered the appropriate standard of care. The surgery itself demands some seriously meticulous, sequential steps so you don't accidentally violate the tract. You kick things off with an ellipse cut right around the opening, carefully following the sinus deep. To help guide you without tearing the tract walls, you gently insert a lacrimal duct probe under direct, continuous vision. Now, if the tract penetrates the spine, you've got to perform a laminectomy, which sometimes means extending all the way up to T12, just to follow it to its absolute full extent. Finally, if the tract actually enters the dura, it almost always does so right in the middle line. You have to open and inspect the dura with extreme painstaking care to guarantee you don't spill any of those toxic cyst contents into the subdural space. Finally, let's dive into our last section today, Section 6, cranial dermal sinus, occipital and nasal tracts. Let's see what happens when this embryological failure manifests up at the cephalic end. Up here, the stalk begins with a dimple located in either the occipital or nasal region. You'll very often spot cutaneous stigmata right at the site, things like a hemangioma, a subcutaneous dermoid cyst, or maybe a patch of abnormal hair. It's really important to note that occipital sinuses extend caudally, meaning downward, and if they do enter the skull, they do so below the torcular hair of Filum. Clinically speaking, these tracts notoriously cause recurrent bacterial meningitis, usually Staph aureus, or aseptic meningitis. Because that risk is so incredibly severe, a full MRI is absolutely mandatory to evaluate for intracranial extension and any associated anomalies, like an intracranial dermoid cyst, which can communicate all the way down into the cerebellum or the fourth ventricle. When it comes to surgical treatment for a cranial dermal sinus, the approach is extremely specific. You have to use a sagittally based incision to allow for the deep exploration you're going to need. The rule is, you must follow the tract completely, leaving absolutely zero behind. That means the surgical team has to be fully prepped and ready to enter the posterior fossa if the anatomy dictates it. We have covered every meticulous detail of these anomalies today, from the fatty filum all the way to the delicate surgical excision of these sinus tracts. We've seen exactly how a tiny 1 millimeter dimple can hide a direct pathway to devastating meningitis or a tethered cord. But it really leaves us wondering, right? As non-invasive imaging keeps getting faster, cheaper, and way more advanced, how are our protocols for routine newborn exams going to evolve? Are we soon going to be looking past the skin of every simple dimple right there in the delivery room? Thanks for joining me on this explainer, and I definitely encourage you to keep questioning what lies beneath the surface.